Right, good morning, everybody. Welcome you to the JJ&J Journal Club and CME morning. I'm just going to run through two recent interesting articles surrounding lung cancer, which doesn't really get as much airtime as it should. This is taken from the Annals of Thoracic Surgery, April 2023. And it's the impact of a federal lung cancer screening policy on the incidence of early stage lung cancer. It's a very, very ambitious study in terms of the numbers of patients involved. This is as it appears in the annals. In December 2013, the US Preventive Task Force recommended annual lung cancer screening for lung cancer for high-risk patients. And the Centers for Medicare and Medicaid Services later announced coverage in 2015. And the impact of these federal decisions at population level is unknown. In the United States, lung cancer is the second most common cause of cancer in both men and women, and the leading cause of all cancer-related deaths. Recent advances in therapy have improved lung cancer survival, but the prognosis remains poor and is highly dependent on the stage of diagnosis. The risk factors for lung cancer, most notably smoking, have been declining in prevalence in recent years. Much work can still be done on the public health level to improve lung cancer outcomes. The National Lung Cancer Screening Trial has shown that screening with low-dose CT can reduce lung cancer mortality in high-risk population. So in this context, they performed a population-based, nationally representative study aimed at examining the impact of lung cancer screening guidelines and the CMS coverage decision based on a quasi-experimental research. They used the surveillance epidemiology and end results database, and this was from 2004 to 2018. And we know that the coverage was initiated at 2013. They included all adult patients between ages of 18 to 80 who were diagnosed with cancer of the lung and bronchus from 2004 to 2018. They excluded all patients where the staging was unknown. Based on the age of diagnosis, they stratified patients into either age eligible, that's more than 55 years, or age ineligible for screening according to the 2013 USB STF cutoff and screening eligibility. The main outcome variables was the age-adjusted incidence of lung cancer, and they used the SEER database for localized or distant lung cancer. A lot of statistical analysis, which I won't go into, and then they looked at sensitivity analysis. To ensure the robustness of the results, several sensitivity analyses were performed. They hypothesized that the increased incidence in early stage disease would translate to a decreased incidence of late stage disease. And they repeated the difference in differences analysis at earlier time points before the advent of screening to assess for robustness of the results. And finally, in an attempt to uncouple the effect of the USB STF announcement from the date of the guidelines actually going into effect and the CMS coverage decision, they repeated the analysis with the year 2015 as a cutoff. All right, the results: 601,896 patients were diagnosed with lung cancer. So it's a very, very large cohort of patients, both before and after the 2013 lung cancer screening guidelines. The baseline characteristics, I wouldn't go into either. It's a lot of data. There were no substantial changes in the demographics of each group before and after the time cutoff. To put the results into perspective, they examined incidence rates per 100,000. So over the study period, the age-adjusted incidence, I'll come to this slide now, the age-adjusted incidence was fairly constant at 13 per 100,000 patients. For all groups, the incidence of early stage lung cancer, both before and after the guidelines remained stable. So the announcement of the screening didn't affect the incidence of disease. However, in the differences analysis, stratifying by age eligibility, there was an absolute increase in age-adjusted incidence in early-stage lung cancer by 3.4 per 100,000 people, 100,000 persons, and this is highly significant, a p-value of 0.007. The second sensitivity analysis examined late-stage disease. So the hypothesis is that you'd have more early-stage disease picked up by screening and less late-stage disease. And this slide shows it quite clearly. At the top is the incidence of early-stage disease, which you can see after 2013. There's an increased detection of early-stage disease and a reduced detection of late-stage disease. And increased to 14.2 per 100,000 reduction in the incidence of late-stage disease. So a significant reduction again, and that p-value was highly significant as well. Other interesting subgroup analysis, women had an increase in early-stage detection far greater than men, but men had a larger reduction in late-stage disease. So you're more likely to get women, more female patients with early disease and less men with late-stage disease. So the conclusions or the comments were that CMS coverage decision in 2015 was associated with a meaningful increase in detection of early-stage lung cancer in an age-eligible population. And this is showing you in the localized disease, all groups, male, female, white, black, Hispanic, metropolitan, and rural, there was an increased detection of localized early disease and a marked reduction in distant disease. So the long and the short of it is that screening decision definitely made a big difference. And so increase in early stage diagnosis more appreciated by women compared to men, whereas the opposite occurred in late stage disease. And this was also found in the Nelson trial, which was the European trial. One problem of any screening program is the concept of overdiagnosis, and it may be one of the reasons why there is low uptake, and I think we've got something to comment about that. The uptake of lung cancer screening is reported to be as low as 3 to 15%, depending on the patient characteristics. The reasons are multifactorial. And the importance of primary care physicians across the country in the United States, and I'm sure it's reflected here, varying degrees of compliance with the guidelines. And we've got our own South African guideline. Most clinicians acknowledge the benefits of low-dose CT screening. And the usual problems such as time limitations with their patients, insurance coverage, lack of appropriate functionality of electronic health records, and the other barriers to screening, including awareness, costs, inconsistent coverage, fear, and travel limitations. Oh, I don't know what's happening to us now. Are we? Hey? Okay. Anyway, I can just carry on with the points that are important. The increase in early detection of early lung cancer should prove instrumental in reducing mortality of lung cancer because of better treatment options. There's been a paradigm shift in the treatment of lung cancer with the tyrosine kinase inhibitors as well as immunotherapeutic agents. And some of these agents have a role now even in the early stage of lung cancer. Cancer statistics in the United States from 2020 demonstrated the largest year-over-year decrease in cancer mortality, and this was then topped in 2021. It would be remiss not to consider lung cancer screening as a possible reason for that. Study limitations. This is an observational study with the inherent confounding and bias. And screening eligibility was determined on age alone. They didn't use smoking. So they just screened anybody between 55 and 80. And obviously, smoking history is important for screening. And then the trends in the use of medical imaging have shown increased rates of CT use, particularly in the last 2 decades. So in conclusion, with this paper, they demonstrate that the effective impact of the USP-STF lung cancer screening guidelines and CMS policy on the incidence of lung cancer by stage of diagnosis. And so there's no doubt lung cancer screening is valuable and is effective. And we do need to embrace it because our patients will definitely benefit from it. And this is just the summary page. The article is available at Kuzam et al. This comes from the Mayo Clinic as well as Loyola University. So that's basically summarizing the whole paper. Then just to tie in with this is from the New England Journal in February this year. Lobar or sublobar resection, peripheral stage 1A non-small cell lung cancer. We've always been taught that patients must have a lobar resection, even for T1 tumors. T1 tumor is less than 2 centimeters in size. And of course, with lung cancer screening, we're likely to pick up more of these patients. And this was a multi-center non-inferiority phase 3 trial in patients with non-small cell lung cancer, staged as T1A, tumor less than 2 centimeters, and they either underwent sublobar resection or lobar resection after intraoperative confirmation of node-negative disease. So obviously we keep staying at a stage 1A. And then they were randomized, and disease recurrence or death from any cause, and secondary endpoints were overall survival, local, regional, systemic recurrence. In 1995, the Lung Cancer Study Group reported the results of a randomized trial comparing lobectomy with sublobar resection in patients with clinical T1N non-small cell. T1 was 3 centimeters, T1A is 2 centimeters. The frequency of local recurrence was 3 times as high with the sublobar resection as with lobectomy, and lung cancer mortality was 50% higher with sublobar resection. These results established lobectomy as the standard of surgical care for patients with clinical T1N0 non-small cell lung cancer. In the decades since, advances in imaging and staging methods has allowed for the detection of smaller and earlier tumors, which lung cancer screening will no doubt do the same. And the situation has rekindled interest in sublobar resection for patients with clinical stage 1A who might otherwise be candidates for lobectomy. A Japanese study recently reported results of a large randomized trial comparing lobectomy with anatomical segmentectomy in patients with clinical 1A. And after a median follow-up of 7 years, anatomical segmentectomy was superior to lobectomy for overall survival as the primary endpoint and non-inferior for lobectomy for relapse-free survival. So this is an extension of that. They report the results of randomized international trial, and they used wedge resection or segmentectomy. So they didn't go for anatomical resection because in reality, anatomical segmentectomy is only performed by about 15% of oncology surgeons in the United States. Most surgeons will do a staple wedge resection. So it's a real world study this way. So between June the 15th, 2007 to March the 13th, 2017, again a good cohort of patients, 1,080 patients with suspected or confirmed T1A were pre-registered to the trial by 125 surgeons. And, this is an inherent strength and weakness of the study, but it's a variability across surgeons in 83 institutions. 697 patients met the preoperative and intraoperative eligibility criteria and were randomly assigned to undergo sublobar resection or lobar resection. Of the 340 patients assigned to sublobar resection, 59.1% underwent wedge and 129 underwent anatomical resection. In a previously reported subgroup analysis, failure to proceed to intraoperative randomization was attributable to undiagnosed benign disease. And this is one of these busy tables again, which is showing that the demographics and the race, sex, smoking status, tumor size, and histological group were pretty comparable across all groups. And this is showing the subgroup analysis of disease-free survival, which didn't really show any significant variability. Tumor location, interestingly, suggested only that right middle lobe resection was probably better, and never smoking was probably better to have a lobar than a sublobar resection. But again, it didn't reach statistical significance. The other interesting thing, at 6 months postoperatively, the magnitude of reduction from baseline and the percentage of predicted FEV1 was greater after lobar resection than after sublobar resection, but the magnitude was not that significant. The magnitude of reduction in the percentage predicted was greater after lobectomy than after sublobar resection, but it didn't really translate to a massive difference. So I presume that's all just got to do with physiological compensation in patients with relatively good lungs. The patterns of recurrence were similar in the two groups. Overall, you had a recurrence 30% in both groups, loco-regional in 10 to 13%, regional in 1.8 and 2.6%. Distant recurrence was the same in lobar and sublobar, and new primary lung cancers were similar. So the outcomes were strikingly similar. And this again just shows you the usual Kaplan-Meier type graphs showing recurrence-free survival and cause of death, which did not reach any statistical significance. And this was up to 8 years after randomization. And this is just a summary, which is available on the New England Journal of Medicine website. So essentially what it's showing is that if we start seeing more of these early cancers, sublobar resection can be carried out. The importance, obviously, is that we have to sample the nodes and accurately stage the disease, which is the most important part. So it's not a surrogate for good surgery if the patient does have any nodal recurrence or nodal metastases detected. And that's why adequate staging is very important. So even if you've got a less than 2 centimeter lesion, you either need to sample the mediastinal nodes or they have to have a PET scan in order for you to accurately stage the patient. Okay, thank you. That's all I have to say. Any comments or questions?
Yeah, I think I've seen an interesting phenomenon now with the in-hospital referrals. So more and more patients are getting CTPAs post-COVID for presenting with dyspnea and having had COVID. And just in the last week, I've picked up, we've had 4 patients. One of the adenal that we did the right upper for. I did another young gentleman who's got a carcinoid. Another guy who's had a small cell tumor, and CTFNA, another lady who's come back as a malignant melanoma. And all of these were asymptomatic from the respiratory point of view. So it just sort of highlights there's a lot of stuff sort of lurking, some clinically, so screening it, and always not, always.
Well, they weren't asymptomatic if they had a CT scan with them.
Yeah. No, they were relatively asymptomatic, history of COVID, and came in dyspneic and had CTPA.
I think we'd call those incidentalomas.
Yeah.
Rather than they're being CT scanned for something other than malignancy.
Yeah.
And I think they mentioned that in this study from Chicago that more people are getting CT scans.
Yeah.
The CT scan quality has definitely improved, and we've got this spectre looming over us of artificial intelligence, which is obviously going to pick up more of this.
And interestingly, the guy who had is a young, fit, athletic guy. He had a 9.8 millimeter nodule, which turned out to be carcinoid. With the Fleischner guidelines,
8 millimeters, not 0.8, surely.
yeah, 8.8 centimeters, yeah. But he, with the Fleischner guidelines, but I chatted to him and he was just paranoid. And he wanted it out. And it turned out to be a carcinoid. Also, the right upper lobectomy had an incomplete, like really incomplete. It looked like the left lobe. The middle lobe was part of the upper lobe. So it was a T1 tumor as well. So it's encouraging that the sublobar type resection is almost incomplete. Essentially, that's what it was.
I just had a patient with severe COPD that we took a lesion out. It's a T1A. And the question was, should she go on to have an lobectomy? I think this would tell us probably not.
Yeah.
The risk of surgery in a 75-year-old with bad lung, better not to have a completion lobectomy. She could have some stereotactic beam to the head. I think the big thing is the companies will tell you, the drug companies are very much on our tails now, because the newer drugs that are exorbitantly expensive are incredibly effective.
Yeah.
But they're 60 to 80,000 rand a month, which is a bit of a problem. They have to bring the price down. Any questions from anybody else?
Maybe we can just share with anyone that's on virtually. They can go and watch our lung cancer screening video if they like on our YouTube channel.
Yeah, there is a lung cancer screening video that we did
From our Coxstab.
on the Coxstab talk.
Yeah.
But valuable. I think all this is going to tie in with going forward, new guidelines, more aggressive searching for lung cancer, because our penetration is maybe 1%. Even in private practice. I think there's no real formalized lung cancer screening, and the primary care practitioners are very, very important, creating awareness surrounding this.
What are those new statistics you were saying the other day about South Africa, the incidence of cancer?
Yeah, cancer incidence in South Africa, recently published, I think going from 2008 to 2019, there's been a 63% increase in the incidence of all cancers. Lung cancer in particular, is the incidence in males has substantially increased, and in females. It's the third commonest cause of cancer in South African females, because of breast and cervix uteri are obviously above that. But still the leading cause of cancer death in South Africa. So cancer is increasing, it appears. Maybe it's better screening or better statistic, but that came from the South African Cancer Society. So there's more cancer around, and we certainly seem to be getting that impression that there's cancer around. And lung is the leader in that. Everybody get a copy of this.
So I'm just waiting for my presentation to load. For those who don't know me, I'm Bruce Kilpatrick.
Get the first page.
Anaesthetist. So we did do a first talk about a month or so ago about lung protective ventilation. Then the brief was to talk about it on ECMO patients. But the sort of introduction to the talk expanded, and we spoke more about just the basics of ventilator-induced lung injury and lung protective ventilation in ARDS patients. So my aim of this talk is just to summarize that presentation so everyone's up to speed, and then we'll talk about ultra lung protective ventilation on ECMO and some of the modes that may or may not be applicable. So in summary, we spoke about, you'll see a lot of acronyms. So VILI is ventilator-induced lung injury. And that's during intermittent positive pressure ventilation or mechanical ventilation. And it's been shown that any type of ventilation can be injurious to the lungs, even if you do it well. And even if the lungs are normal to begin with. So say you're intubating or ventilating a patient with a head injury, if you can injure the lungs with your ventilation. Obviously, we don't have many options in terms of not ventilating, but it is just something to be aware of. The mechanisms are multiple. You have volume trauma, barotrauma, which is pressure trauma, atellect trauma, which is the atelectasis and the opening and closing of alveoli. And then this concept of P-SILI, which is patient-induced, spontaneously induced lung injury. So those are the patients who are working very hard on their own. They're taking big breaths, they're tachypneic. We saw this with the early COVID patients, and that can cause lung injury in and of itself. We spoke about the ARDSNet study, so that was in 2000, a sort of groundbreaking study that changed the paradigm on lung protective ventilation, showing that lower tidal volumes of 6 to 8 mils per kg, limiting your peak pressures and your plateau pressures, appropriate PEEP, and permissive hypercapnia showed a marked decrease in the mortality of patients with ARDS, and that's kind of been our standard of best lung protection up till now. And then I'd just like to touch base on just some measurements or bedside calculations aimed at just measuring the dose, if I can use that term, of the ventilation. It's a graphical representation of the mechanisms of lung injury that we spoke about. So on the top left, you've got a normal alveolus. Top right, you've got an alveolus during disease, during lung pathology. You've got edema fluid in the alveolar sac. You've got interstitial edema. That alveolus, if you expand it too much, it's going to damage cells, cause cell necrosis, and that's your volume trauma. Again, pressure can damage alveolus, barotrauma, pneumothoraces, bronchopleural fistulas, and that leads to the bottom graphic, where you get the cytokine storm or pro-inflammatory mediators that are produced locally and then spill into the systemic circulation and cause global multi-organ dysfunction. You get acute kidney injuries, you get bowel dysfunction, all from the lung as a primary cause. So where are we today? We talk of lung protective ventilation. This is the ARDSNet data. So tidal volumes of 6 to 8 mils per kg. Remember, we're talking about predicted body weight. So you don't go on the patient's actual body weight. So if they weigh 150 kilograms, you're not giving 1.2 liter tidal volumes. Their lungs are still the size of a 60 kilogram person. So it's very important to use their predicted body weight. Plateau pressures below 30 millimeters of mercury. Appropriate PEEP or optimum PEEP. There are sliding scales looking at your inspired concentration of oxygen and how much PEEP you should be using. Again, it's very patient dependent. We'll go into that a little bit further. And then I put positioning in. And we spoke last time about proning patients. And that's probably a key point that we'll mention further as well. Again, this is just a graphical representation of the previous slide. So prone positioning reduces volume trauma, atellect trauma, and biotrauma. Early neuromuscular blockade may reduce initial trauma. Again, that's just in the initial phases of a patient's disease. We're very much against long-term neuromuscular blockade in the ICU. Appropriate PEEP or higher PEEP may be beneficial in ARDS. Low tidal volume is definitely beneficial in ARDS. And then there's some other modalities, obviously ECMO, which are the next step up in terms of lung protection ventilation. This was just a graphical representation of proning patients. On the right, you have the benefits and the physiological causes or rationale for it. Remember, if you're supine, most of your lung is dependent, and in disease will be edematous and the alveolar will be collapsed. gives you a big VQ shunt. That means you have a lot of blood going to lung that isn't being ventilated. And that gives you a shunt and gives you hypoxemia. You prone a patient, you improve the VQ mismatch substantially. You allow those dependent, soggy, flattened alveoli to expand, and you preferentially perfuse the alveoli that are now working better. A significant study from 2013 was a randomized control trial, prospective, multi-center in Europe, and it looked at mortality with proning patients with severe ARDS. So they managed to get just over 230 patients to the prone group and 229 patients to the supine group. And there was a significant mortality benefit or difference in 28 days. 16% for those who were proned and over 32% for those in the supine group. Obviously, they chose their patients very well. They're very good at proning patients. These are first world ICUs with lots of resources. But I think this is a very important study. It's called the PROSEVER study, and it's freely available in the New England Journal of Medicine. Of note, they talk about the dose or the length of time being proned, and their minimum was 17 hours a day in the prone group. So this is not turning a patient for 12 hours or for one shift. And overall, for their patients who were prone, it was close to, I think, 70% of the time they were on a ventilator, they were proned. So these are significant time that they spent being proned. And of note, they didn't have any significant differences in complications with proning patients. Going back to the oxygenation index, so this is just a calculation that you can do at the bedside. And the reason I'm sort of fixating on it is because we change the ventilator settings all the time. One doctor comes in, puts the PEEP up by 2. I come in, I put the PEEP down by 3. The next doctor puts the FI2 up. Next doctor changes the ventilation mode. And day by day, you don't know if you're improving the situation or worsening the situation. So it's a simple bedside test. You look at the oxygen index. You take the FI2, the peak airway pressure, and the PaO2. You just put it into a calculator. There's lots of them online, and it spits out a number. The lower the number, the better. And these are more data on the right for a pediatric population, but I think it's a good guide for us in terms of when to consider ECMO and when it looks like you're doing all right. And the zone of 25 to 45, that's over a 40% mortality rate, and those are significant numbers. So this takes into account all the ventilator changes that you've made, and then gives you a number that you can hang your hat on, and you can track daily to show whether your ventilator changes are actually changing any of oxygenation. So I just thought I'd put up 3 examples. So on the left, we have a patient on pressure control with FI2 of 60%, peak airway pressure of 20, and the ventilators do measure this. So you just have to go into the menu and pick that setting, and a PaO2 of 8 kPa. In the middle patient, we've got a patient on volume control, FI2 of 80%, peak airway pressure of 14, and their PaO2 is 8.3. And say it's the same patient the following day, someone's changed the ventilation mode to pressure control, decreased the FI2 to 70%. The peak airway pressure is now 24%. Sorry, mean airway pressure. Those are mean airway pressures, not peak pressures. And the PaO2 is now 8. Now, which patients are doing well and which ones should you be worried about? Obviously, there's lots of other factors, but it's just a representative. So the first 2, basically the oxygenation index is equivalent. It's the same. So their lungs are probably in a similar state. The patient on the right has a much higher oxygenation index, and obviously the mean airway pressure is 24, is much higher. You're requiring a much higher pressure to get that PaO2 to the same level. So their lungs are much more damaged or in much more fragile state. So easy bedside test to track, and also gives you some numbers to guide you whether the patient needs ECMO. These are the Alfred guidelines, when to consider VV ECMO. This talk is primarily on lung pathology, so I'm not going to discuss VA ECMO. So VV ECMO is considered when you're unable to maintain a SaO2 above 88% or pH above 7.2. That's in primary hypercapnic respiratory failure with safe mechanical ventilation settings. So those are the odds net settings. And you've also considered the following. You've done a trial of high PEEP or appropriate PEEP. You've neuromuscularly blocked the patient to give you the best chance to ventilate them. You've considered proning them, or you have proned them. And the other factors of you've dried them out so the lungs can oxygenate. You've considered recruiting if appropriate. You can consider trials of pulmonary vasodilators if available. And you've optimized their cardiovascular system. If someone's cardiovascular unstable or hypertensive, they're not going to be ventilating effectively, or their gas exchange is not going to be effective. So that to me those are not scary numbers. We see SATs in the low 80s all the time. We see pHs lower than that all the time. And I think it's very enlightening that almost a paradigm shift for all of us, that if you can't get reasonable numbers with lung protective ventilation, then that is the time to consider VV ECMO before you do any further damage to the lungs. These are, again, from Alfred about patient selection. I'm not going to go through this, but it's a very interesting slide, and I would recommend just going through it in your own time. And just to re-emphasize that patients with ARDS don't die from hypoxia or hypoxemia. They die of multi-organ failure. And that's part and parcel of our lung ventilation injury that we're causing. And so yes, ECMO, we're using it to improve gas exchange, to reduce tissue hypoxemia, reverse the profound hypoxemia, and reverse uncompensated hypercapnia. But probably more important than that, it's allowing us to rest the lungs and to avoid injurious mechanical ventilator settings. And I think that's key. So how does it do that? Well, we limit the mechanical forces that we're applying to the lungs. We can reduce tidal volume, plateau pressure, driving pressure. We reduce that local biotrauma that then spills into the pulmonary and systemic circulation that then goes on to cause multi-organ failure. So ECMO can limit all of that bad cascade. What settings do we use? Well, this is a busy slide that I'll highlight for you. These are studies looking at the impact of mechanical ventilator settings during ECMO in patients with ARDS. So the first one was just over 100 patients, a retrospective observational study. They showed that higher plateau pressures on the first day of ECMO was associated with ICU mortality, a higher mortality. The following study was also a retrospective study, 168 patients. Their mortality was just under 30%. They showed that a higher PEEP during the first 3 days of ECMO was independently associated with a lower mortality. Fortunately, I looked at the study and I couldn't find what their higher PEEP actually was. I'll keep looking. Systemic review looked at mortality on ECMO patients, and they found that a combined tidal volume of less than 4 mils per kg, predicted body weight, and a plateau pressure less than 26 centimeters of water during ECMO had a lower mortality. Another retrospective observational study showed that decreased plateau pressure showed lower mortality. There is the second from the bottom, prospective cohort study that showed that mechanical ventilation settings during the first 2 days of ECMO did not impact the prognosis. So there's mixed data, but certainly there's enough there that I think can point us in the right direction. Obviously, the take home from these studies is that lower pressures, lower tidal volumes during ECMO is all appropriate and leads to lower mortalities. So then these are international studies and consensus from international groups looking at what settings to use on ECMO. From the CESAR trial in 2009, they used pressure control ventilation. They kept their peak inspiratory pressure below 25, PEEPs between 10 to 15, respiratory rate of 10, and FR2 of 30%. The ELSO guidelines, which is the Extracorporeal Life Support Organization, they had a graded or titrated approach. So initially, first 24 hours, heavy sedation, pressure control ventilation, PEEPs as high as tolerated, to avoid inhibition of venous return. Plateau pressures below 25, respiratory rate 5 breaths per minute, and then slowly increasing from 24 to 48 hours. You allowed a bit higher pressures, and then after 48 hours, decreasing the sedation, allowing spontaneous breathing, aiming to extubate or do a tracheostomy within 3 to 5 days. And that's quite enlightening to me as well, is that we're not talking about weeks or months of keeping these patients flat and not breathing. We want to get them awake and breathing as soon as possible, and I'll go into that a little bit further as well. The EOLIA trial, their settings were broadly similar. They used volume assist control, but basically the same numbers. And then the ECMO-Net Expert Opinions Consensus Conference from 2018, again, plateau pressures less than 24, tidal volumes less than 4, PEEP greater than 10, driving pressure less than 14, respiratory rate less than 10. So summarized, those are the numbers there. Let's go into them a little bit more detail. So tidal volume, 4 mils per kg or less. And very importantly, they titrated it to a plateau pressure less than 24. And if they needed to go lower than 4 mils, they did. Obviously, the lower the tidal volume, the higher the risk of atelectasis. But there are ways to mitigate that. There's no actual studies or evidence showing that an absolute number of your tidal volume is going to get you a better outcome. It's all part of the global picture. PEEP, same principles apply to patients not on ECMO as patients on ECMO. Higher PEEP gives you a higher mean airway pressure. And we've shown that if you have a higher mean airway pressure, you typically have a higher PaO2. That can be a good or a bad thing. As an extreme example, if you take any patient and you ramp up their mean airway pressures to as high as you can, you will get a good PaO2, but you will be damaging the lungs. So it's not just about targeting a PaO2 or a SpO2, it's about an appropriate airway pressure. And if you can get a safe higher airway pressure, then that will give you better oxygenation. PEEP allows you to reduce the strain and stress on the alveoli and to maintain recruitment. My last talk, we talk about the paperclip model. So if you think of the alveolar as a paperclip that's being opened and closed continually, eventually it snaps. And that stress and strain is the same on the alveolus. With PEEP, you avoid that opening and shutting continually. It decreases lung injury and decreases intrapulmonary shunt. Obviously, it's not without risks. The higher PEEP you have, the higher intrathoracic pressure you have, it increases your pulmonary vascular resistance. It can decrease your venous return. It can lead to hemodynamic instability. Optimal PEEP can be assessed at the bedside for the individual patient based on their gas exchange. You can look at the PEEP and FI2 tables. That's on ARDSNet studies. You can look at their respiratory mechanics. You can look at their pressure volume curves that most ventilators can measure. Obviously, it's easier to do on a patient who's completely sedated and paralyzed, but you can get an assessment if your PEEP is being effective. You can do bedside imaging studies, ultrasounds. I think lung ultrasound would be very useful. It's obviously a user skill that has to be replicated, so I don't have those skills. We don't typically do them at the bedside. Some centers are taking patients to CT to assess their recruitment. Obviously, that's very labor intensive and has its own downfalls. But there are ways of actually assessing your PEEP and recruitment. So according to the guidelines that we've looked at, optimal PEEP is probably greater than 10. Some say as high as tolerated to avoid inhibiting venous return and hemodynamic instability. And the one study showed that a higher PEEP in the first 3 days had a significantly lower mortality. That was from Critical Care in 2015. I've spoken a lot about plateau pressure. What actually is that? It's the pressure obtained at the end of inspiration after a 0.5 second inspiratory pause when the patient is sedated and paralyzed. So it's at the end of inspiration, before no gas is moving in or out of the chest, the patient's not making any effort, and that's the plateau pressure. So it's a static measure. In the ARDSNet trials, looking at lung protection, we wanted to keep that below 30. In ultra-protective lung ventilation on ECMO, you want to keep it below 24. The higher the plateau pressures, the higher the mortality. Driving pressures is the difference between that plateau pressure and the PEEP. So basically, pressure you need to get the air into the lungs at the start of inspiration to the end of inspiration. It's inversely proportional to compliance. Let me just try to explain that in a slightly more user-friendly way. If you think of a balloon that is very stiff, that is non-compliant, you need a high driving pressure to open the balloon. If you've got a very compliant balloon, a very easily inflated balloon, then you need a low driving pressure. And that's just a mark. If you've got stiff, damaged lungs, it's going to be very uncompliant or very stiff, and you need a higher driving pressure to open it. Well, obviously, if you have a high driving pressure, you have a worse outcome. That's kind of saying patients with sicker lungs do worse. It's kind of self-evident. But they did show that a high driving pressure during the first 3 days of ECMO was independently associated with mortality. A very elegant study from multi-center group in Toronto looked at the relationship between driving pressure and plasma levels of all those pro-inflammatory mediators and cytokines. And they showed a linear relationship, but the higher the driving pressure, the higher the amount of pro-inflammatory cytokines you had. We've mentioned this in the previous talk, transpulmonary pressure. It's basically the difference between the alveolar pressure in the alveolus, and the pleural pressure. It's not something we can measure directly, but the esophageal pressure is by and large the same as pleural pressure. You can put a manometer down the esophagus and measure the pressure, which is then analogous to pleural pressure, and then you can measure the transpulmonary pressure. The advantage of this, and it's not something we do routinely, is that it individualized for the patient and measures the patient's individual physiology, especially in obese patients. A lot of that driving pressure and peak pressures is from the chest wall. It's not actually from the lungs. So if you take a patient who's 150 kilograms and you ventilate them, you're going to see very high peak pressures, you're going to have very high plateau pressures. If you measured their transpulmonary pressure, by and large it would be normal. So their lungs are actually don't have high pressures. You're measuring the pressure from the chest wall. Certainly there was a study from China, and they looked specifically at managing their ventilation on VV ECMO, measuring the transpulmonary pressures. And the transpulmonary group, was just over 100 patients, had a significantly lower mortality rate. 48% versus 71%. That's significant. And it was statistically significant. Is it something we should be doing? I haven't seen it here. There are ways of doing it. It is more experimental and technical. You've got to put a pressure manometer down the esophagus. There are technical limitations to it. But maybe it's something we should be looking at in our obese patients. Respiratory rate, again, lower is better. The higher the respiratory rate, the more energy you're putting into those lungs, the more mortality you're going to get. Fraction inspired concentration of oxygen, again, lower is better. By and large, your oxygenation is taken care by ECMO. Obviously, and I'll defer to the experts in the room, the longer your ECMO run is, the less effective your oxygenator becomes due to clots and what have you. And then you may need to rely more on your FiO2 from the ventilator, but I'm not going to spend any more time on that. And then spontaneously breathing on ECMO. There's lots of studies looking at it. There's lots of pros and cons. Certainly during the initial phase or the initiation phase, you've got an unstable patient who's often peri-arrest in extremis. I would say you don't want the patient doing anything. Those patients are heavily sedated, paralyzed, and you want to give your lungs the best chance to recover. Once we're in the weaning phase, there are significant advantages to having a patient breathing spontaneously. One, their diaphragmatic and respiratory muscles don't waste away and become atrophic. That happens almost instantaneously. They decondition very, very quickly, which is why we don't like long-term neuromuscular blockade or deep sedation in any ICU patient. Also, the benefits of spontaneous ventilation is that it does aid gas exchange, especially removal of CO2, and also it preferentially improves recruitment. If you recruit with a positive pressure breath, you're giving high positive pressure into the lungs. Generally, that air and pressure goes into good alveoli and can overdistend the good alveoli not get into the bad alveoli. If someone's breathing on their own, it preferentially opens all alveoli, so you actually get a better recruitment. So for long-term ECMO, we definitely want spontaneous ventilation on top of their ventilation mode. A lot of the studies didn't look specifically at mode. So when I talk about mode, you're familiar with volume control and pressure control. Something that's coming more and more is APRV, or airway pressure release ventilation. And I'm going to spend a little bit more time on that. But I would emphasize that at the end of the talk, it's more important what goals you achieve rather than the mode you use. You can achieve any of those numbers that we looked at with any mode, then you're doing a good thing. It really, the mode is less important than how you use it. So APRV is a pressure-controlled mode of ventilation that delivers an almost continuous positive pressure with intermittent time-cycled short releases to a lower pressure. It gives you an increased mean airway pressure. Over the whole respiratory cycle, your mean airway pressures will be higher. And as we mentioned before, that's going to give you better oxygenation. It follows the concept of open lung ventilation. You're not opening and closing it the whole time. It remains open for a lot longer time on the respiratory cycle. And very importantly, it allows spontaneous ventilation. The naming of it can get very confusing, especially with different makes and brands of ventilators. Every company and brand has its own acronyms, its own proprietary software. It can get very confusing as to what mode is what. With the newer ventilators that came in during COVID, I didn't know what some of the modes were. So it's very confusing. So the most important thing is that there's basically 4 things that you look at or set. It's the P high, or the pressure high, and that's the highest level of pressure applied during the respiratory cycle. And this accounts for the majority of the respiratory cycle. The T high is the time in seconds spent at that high pressure. The P low is the low pressure applied, and the T low is the time spent at P low. Look at the left-hand diagram. This is a screenshot of the ventilator. So the top, do you have a... There's a point. Anyway, that's all right. So top left graph, the square blocks. That is a pressure time curve. Thank you. Perfect. So that's a pressure on the y-axis and time on the x-axis. So your P high is this line here. And then the time, T high, is the time spent at P high. Then you have the release to a low pressure, and then you go back up. So you can see most of the time is spent at this high, at your P high, which is, the actual number is immaterial. I think it's set at 24 centimeters of water. And you can see this number here, your ventilator's measuring the P mean, the mean airway pressure during the whole airway cycle. And you'll see, I noticed whenever I switched from volume control or pressure control to APRV, is that for the same peak and plateau pressures, you would get a higher mean pressure. So that determines your oxygenation. So that's why you get better oxygenation with APRV for the same pressures. You're spending more time at the higher pressure, but you're not damaging the lungs while you're doing it. On the right is a pressure control ventilation graph. So you've set the peak inspiratory pressure and you set the respiratory rate. The ventilator delivers a pressure to the high pressure, holds it there, and then cycles with the respiratory rate. And then the bottom line is the PEEP. You'll notice here this returns to 0, and you'll ask, well, why are we returning to 0? What has happened to the PEEP? How do you set the PEEP? You don't specifically set the PEEP on APRV. What you do set is you set the low pressure. They recommend setting the low pressure to 0. So are we not then risking de-recruiting the lungs and undoing all our hard work? Yes and no, there is that risk. But with this mode of ventilation, your time spent at the low pressure is measured in milliseconds. You normally set it at 0.4 milliseconds. So often the lungs don't get down to 0. It does in this graph, but often they won't get down to 0, and the time spent there is minimal. It is one of the criticisms of APRV, but yeah, that's the story with PEEP. So you're not setting PEEP with APRV. Also, you're not targeting your odds and end criteria. You're not targeting a tidal volume here. You're not targeting a plateau pressure. Your ventilator may or may not measure those specific criteria. What you're doing is setting a P high, and you're setting it at a reasonable level. It's 24, and then you're determining. You will then determine your T low will also aid in CO2 removal. So one of the problems I've found with APRV is that you can get hypercarbia or CO2 retention. And that's really probably my ham-fistedness not setting it up properly. If you set up your T low and your P low appropriately, you should be able to control your CO2 appropriately. So the physiological rationale, the reason for using APRV is that you get higher mean airway pressures with lower peak pressures. It's basically a constant recruitment maneuver. You maximize alveolar recruitment and you decrease stress and strain. It allows respiratory spontaneous breathing. So you can spontaneously breathe at your high pressure. Your patient can breathe in and out at the high pressure, and your patient can breathe in and out at the low pressure. Something that conceptually took me a while to get my head around. They can breathe throughout the whole APRV cycle. We've mentioned the benefits of spontaneous breathing, and you're not targeting a specific tidal volume. There's certainly compelling animal studies that APRV shows much less inflammatory cytokines and better oxygenation. There's been mixed results in human studies. There's no large randomized control trials. This is from an unfortunate pig. So on the left, not the part of a pig's anatomy we're used to seeing. This porcine model on the left is a lung that's been ventilated with APRV. So it looks pink, healthy, not edematous, not so bad, no bad stuff in it. This is a pig lung that's been ventilated with lung protective ventilation. So not injurious ventilation that we think of. This is best lung protective ventilation. And you can see it's edematous, there's fibrous tissue, there's lots of bad stuff happening here. So this is an extreme animal model, but clearly there is a signal here that APRV might be beneficial. So to summarize, what to take home from today: strict adherence to lung protective ventilation in all ventilated patients, but especially those with acute lung injury or ARDS. We should be optimizing them and definitely looking at positioning, specifically proning them in appropriate patients. Early consideration of ECMO. We want to get in before the lung has been damaged beyond repair. Once they're on ECMO, ultra lung protective ventilation. And then for me, and then probably the ICUs, maybe we should do some bedside teaching. I've got a lot to learn, but certainly maybe we should become more familiar with APRV in this setting. And any questions?
Wow, that was cool.
Thanks very much, Bruce. I think that was timely as well. It's interesting when you look at the EOLIA study and the CESAR trial. Everything before 2018, APRV didn't really get a mention, although it's been around for the last 10 or 15 years. But I think COVID has taught us a lot, and certainly APRV seems to really have found its place. The way I look at APRV is that it's a lot of PEEP for a long time, a little break in between, and I think that's probably why it works. And I think the other thing, all those studies showed that you just need a short period of injurious ventilation, and the lungs are shot. That first 6-12 hours, the first 3 days, you even though the patient's on ECMO, you damage the lung. And before they go on ECMO, the lungs are damaged, and so it comes back to looking for early referrals, and then babying the lungs. At the Alfred, they even talk about they don't talk about APRV in their guidelines, but they talk about dropping the tidal volume to 2 mils per kilo if the lungs are shot. You know the lungs are shot. Let the ECMO do the work. Leave the lungs alone. Avoid that whole systemic injury from injurious ventilation. And there was another thing, and it's all about those first 3 days, first 6 hours. How much we injured, and I don't think we realized how much we damaged the lungs. what tends to happen with the ECMO patients, once you put them on and you put them onto APRV, when the lungs are bad, you do need the peak airway pressure, the D high at around 24.
Yeah.
But you see and that's the nice thing about the newer ventilations, you can see the compliance changes. And you can also drop that D high, because you obviously don't want the volutrauma, you don't want silly tidal volumes either. You're not targeting tidal volumes, but you don't want tidal volumes.
Yeah.
And what we found, we've been able to drop that D high down to 18.
Yeah.
The other thing I've noticed with people that are using APRV, the T high is not long enough.
Yeah.
And it's almost like they're trying to copy normal volume control ventilation.
There's a distinct difference, mindset difference in how to apply it.
Well, I obviously got thrown into the deep end this when we went to North Park, because everybody was getting APRV and everywhere, and so it became an immersive experience in ventilation that I didn't really understand very well.
Yeah.
That I learned a huge amount from that, especially Guy Richards, Paul Williams, and Mervyn, who have embraced it for that purpose. And I think those the galley girls from the States, who the number of times they get asked to see patients for ECMO who just not being ventilated right.
Yeah, so if we can optimize and get them.
Some of the patients, you just put them on APRV, and 90% of the referrals. Yeah. Obviously, including positioning, because they're quite aggressive with proning too.
Yeah.
So. And proning makes a massive difference. But I know everyone's a bit nervous of it. If you can avoid ECMO, it's kind of better.
Yeah.
So something that we have to think about on ECMO referrals as well is, can we prone the patient? Prone the patient. They're not in extremis, maybe that's something we need to be more aggressive. But thanks very much. I think that's
I also wanted to just share, I don't know every brand of ventilator, certainly not, but we used to measure the esophageal pressure on the Avia. The nursing staff were expected to do it to get those pressures that we were speaking of. The Avia has software in that will calculate it, but you put in just like a esophageal tube, like a nasogastric. Yeah, it's got it on. I know the ones here that can do them, the ones in this hospital. So if we have a patient like that, just check it out. Yeah. I know the Vila can't, but the Avia can. Don't know about the others. That was a cool talk. I think you must send us this talk and then you must post some of these slides in our group. They're very handy.
It's changed. The last 5 years, it's changed ventilation.
Yeah.
I suppose we've got to thank COVID for that. Yeah. Hopefully it can translate to benefits for another area of these questions.
Would Mervyn Merle, Guy Richards do it Friday morning talk, do you think?
I'm sure Guy will.
Yeah. It'd be very...
Mervyn is fantastic,
Yeah.
Yeah, that'll be awesome.